First, we're going to start with palpation. So we have the coronoid process. So if you locate the olecranon, which is the biggest and most prominent structure on the back of the elbow, you're going to fall off medially and then fall a little bit distally, and you'll feel that ridge. It's a bony prominence, so it's pretty easy to find. It's more on the medial side of the elbow as you follow the ulna down. And then more laterally, you want to find the radial head. So if you come off of the lateral epicondyle, you'll fall into the joint space. And then to make sure you're on the radial head posteriorly, you can also find the anterior part through the cubital fossa. You just kind of have to sink in through those tissues. But to ensure that you're on it, you can passively pronate and supinate the arm, and you'll feel the radial head move under your fingers. So we have our medial and lateral epicondyles, coronoid process, and then the radial head. Also, a relevant structure for this area common with elbow pathologies is right above the lateral epicondyle is the supracondylar ridge, which is where some extensor radialis tendons attach, which can often be painful as a pain provocation test, which we'll talk about later. So we're going to start off our joint play with distraction or traction of the ulna and the radius, so for the humeral ulnar joint and the humeral radial joint. So we're going to start off with humeral ulnar. So this one is a ice cream scoop motion. So you're going to start with the arm in the loose packed position, which is 70 degrees of flexion and about 10 degrees of supination. And then on the inside of the patient's arm, you're going to locate the ulna, and then with your fingers, you're going to get right on that ulna, and then with your outside hand, we're getting underneath to the joint space. And we can also use the rest of the hand to provide stability and stabilize the humerus. And then I'm doing an ice cream scoop motion there to distract the ulna to allow the olecranon to clear from the humerus. And then from here, we have humeral radial, so you're going to come on the inside of the patient's arm and then locate the radial head, so falling off of the lateral epicondyle into that joint space, and then feeling the radial head and that joint space. You can use a golfer's grip on the distal radius, and then using the arm up against your body, doing a little bit of core rotation so your arms don't have to work as hard to create that distraction force. It's also worth noting that you want to try to avoid being in full extension because it's hard to get any mobility there. It's better if you're in that flexed position as much as you can. You can also move with the patient. It's hard to be on top of them. So do as much as you can. Next, we have flexion and extension of the humeral ulnar and humeral radial joint. So I have to do a couple adaptations, because this bed is really springy and not hard. And in addition to that, I have really small hands and he has a really big forearm. So I'm doing my best. But we're going to start with humeral radial joint. So radius here is on the outside. So we have a towel underneath the distal humerus to provide what little stability we can get with this bed. And then from there, we're going to have our hypothenar eminence on, or our thenar eminence on the lateral forearm with our patient supinated. And then we're going to use our spare hand to palpate the joint space. And then with your forearm in the direction of the force, you're going to create that flexion. And you can do that at any part in the range. You do it farther down here. And then for extension, it's a little bit easier for me to get on the inside and then use my arm to not only prevent osteokinematic motions, but also palpate the joint space there to get my forearm in the direction of the force to get extension at the humeral radial joint there. And you can do that throughout the range as well, just coming with them. From here, we have humeral ulnar. So with our ulna more on the inside. We're again going to be palpating with our free hand and then providing that mobilization. I'm also using the rest of my hand to try to stabilize the humerus as much as I can. And you can do that at different parts in the range as well. And then for me, I can't get a good grip if I come this way. I can get a bit of a grip, but it's not the best. To get extension this way for humeral ulnar, just because of the shape of his forearm. So instead, I get a little bit more progress by using a similar grip to traction and just pulling instead throughout the range. And then using my hand to stabilize and palpate in that humeral ulnar joint space. Next, we have the radial ulnar joint. So for joint play in this joint, the radius is moving in a ventromedial or dorsolateral direction. So we're going to hold and stabilize the ulna with our leg and our spare arm while we are palpating in that joint space, and then we're going to be moving the radial head. So with our forearm in the direction of force, we can move dorsolateral and ventromedial and trying to minimize the movement of the ulna and the humerus as a result. You also get a little bit more mobility if your hand is pronated. Let's see if we can get a little bit of extra motion there, and we do, especially with the lateral glide. So that's radial ulnar. So the other two glides we have are a general lateral and medial glide of the elbow. So we have our patient again in loose pack position, and then we're going to use one hand to stabilize the humerus and the other to provide a lateral glide. Hopefully my shoulder is not in the way. So we have a lateral glide here, and then we can just switch our hands and maintain that same position, stabilizing on the medial side now, and then providing the force through the lateral side for that medial glide there. So next we're moving on to special testing. So we're just going to start with the Cosen's test. So we're focusing on the lateral epicondyle and pain located in that region here. So this is a pain provocation test. We're going to start with our patient at 30 degrees of flexion, and then we're going to have them make a fist. And then we're going to move that fist into extension and radial deviation. And then we're going to have the patient hold that position, and they're going to resist against us. And while we're doing that, we're going to palpate the lateral epicondyle in that region. So go ahead, resist against me. And if there's any pain reproduced there, that could be indicative of lateral epicondylgia. I can never pronounce that quite right. And then from there, we also have golfer's elbow test. So this is focusing on the medial epicondyle and pain provocation there. So for this one, the elbow is going to be extended, and then we're going to create, we're going to supinate the arm, and then we're going to create wrist and finger extension in order to put stress on the flexor muscles of the wrist, so that tension of the wrist flexors could reproduce that pain at the medial epicondyle. Sorry for that. So we'd also want to be palpating there as well to see if that is provoking any pain. Common of golfer's elbow. From there, we have tennis elbow. So also with our arm in extension, instead, we're going to be focusing on the fingers specifically digits 2 and 3. So I'll put my camera a little lower there. So for this one, we're focusing on extensor carpi radialis longus and brevis. So extensor carpi radialis longus specifically impacts digit 2, and then brevis for digit 3. So with the arm in extension, we're going to resist finger extension of both of those motions. So you're going to push into me here, and then push into me again here, just with those fingers. So if either of those reproduce pain at the lateral epicondyle, that could specifically tell us which muscle is causing those symptoms at the lateral epicondyle. From here, we're going to also go off of extensor carpi radialis longus and brevis for the Mills test. So for this one, we're going to have the patient start with elbow flexion, and then we're going to do finger and wrist flexion here. And then we're going to palpate the radial head. And then from here, we're going to move a little bit anteriorly. So as we extend the arm out, we're going to be pushing on that tendon attachment, which could potentially be pain-provoking and cause, try that one more time, because we had a positive test earlier. Any pain there?
No.
Cool, that's exciting. So as you're pushing on that radial head and bringing that a little bit more anteriorly, that causes a bend at that insertion site of those muscles, which could potentially create additional tension to reproduce that pain. And this is also kind of similar to the motion for the upper limb tension test. So we want to make sure that if the pain is reproduced, it could cause radial nerve pain in addition to the muscular pain. So we want to make sure we ask what kind of pain they have with this test. So from here, we have valgus and varus testing. So we have the moving valgus test, in which we're going to externally rotate and abduct the shoulder. And then we're going to hold the humerus and bring the forearm from 30 degrees of flexion outwards to 90, and then back again. So this is a motion testing the integrity of the ulnar collateral ligament on that medial side as we create that valgus motion. And then from here, we can do additional valgus testing by stabilizing the humerus and providing a lateral glide at 0 degrees, 30 degrees, and 60 degrees. And then in addition, we can do varus testing as well on the other side by simply switching our hands and doing, try not to be in the camera. So we have 0 degrees, 30 degrees. There we go. So at 0 degrees, 30 degrees, and then 60 degrees to get varus testing as well. Last of the special tests, we're going to do the biceps integrity cluster, which includes the hooks test, passive pronation, and the biceps crease interval test. So for the hooks test, we're going to have the arm at 90 degrees and supinated. And then we're going to locate the biceps tendon. If we have any issues with that, can you squeeze your bicep for me? Push it in. Beautiful. And then relax. So we're going to get a hold of that biceps tendon, and then you're basically using your fingers as a hook, as the name implies, and you're pulling that biceps tendon away. And you're just looking to feel tension from the bicep to ensure that the bicep is still intact. So from there, we have passive pronation. So an alternative test to look for biceps integrity is, again, by having the arm close to 90 degrees, and then all you're going to do is passively supinate and pronate, and you're just looking to see if the biceps belly moves, which you can see clearly. It's pretty hard to see through the video, but I can see it up close. So I know his bicep is intact. And then last but not least, we're going to use a pen for the last one. So for the biceps crease interval test, we're going to be making 2 lines. So first, we're going to make a line in the crease of the arm, just where the natural crease would be, as you can see, because most people have a wrinkle there. But we'll make a line there just to make things official. And then from there, we're going to be looking at the patient's bicep and then looking to see when the muscle belly seems to stop. So for me, looks to be about here. And then what we would do is take a measuring tape or a ruler and measure that distance. In most normal patients, it's about 6 centimeters or a few inches for the rest of us. And from there, we're going to be looking to see if it is either way lower or way higher, which could potentially indicate either a distal tear of the biceps tendon or a proximal tear of the biceps tendon. If it tears proximally, it's known as Popeye sign, which is where the muscle belly is much lower. My dad had this. So his muscle belly was much lower than 6 centimeters, so that distance was more like 1 or 2 centimeters. But it could also tear here, and it could be higher as well. It's just less common. Last but not least, we have neurological assessments. So we're going to do the tunnel sign within the cubital fossa, and then we're going to do the elbow flexion test as well. So for the cubital fossa, we're targeting the ulnar nerve. So we're going to go on the medial side of the elbow, falling off of the medial epicondyle, and in between the medial epicondyle and the olecranon is a little groove. So here we're going to be palpating and then doing little taps here. And then if the patient has any symptoms, that could potentially be neurological, going down their hand, or causing tingling in their forearm or hand there. That could be positive for some ulnar nerve pathology there. So you can do the taps like 4 to 6 times. And then for the elbow flexion test, this is also assessing ulnar nerve tension or pathologies. We're going to have our patient bilaterally flex their elbows to end range all the way up. And then extend your wrist, so keep it there. So mirror me, beautiful. And then they're going to hold this position for anywhere from 30 to 90 seconds, depending on what source you look at. But for the purposes of this video, the next progression from here would be to have them abduct. So I'm going to have him mirror me. So what you're going to do is this. Beautiful. So you're going to have them abduct their arms to 90, keeping sure that they have that maximal wrist extension and that their biceps are flexed, or their elbows are flexed all the way. And if they have any neurological symptoms with that, we could have some ulnar nerve pathology there.